Good evening. On behalf of ANZ Head and Neck Cancer Society, welcome to our first webinar for 2023. My name is Khoo, radiation oncologist based in Gold Coast. It's my pleasure to facilitate the webinar tonight. Next. ANZ Head and Neck Cancer Society acknowledges the traditional owner of the land on which we gather today and the many lands on which we undertake our work. We recognize their continuing connection to these lands, water, and culture, and pay our respect to their elder past, present, and emerging. Next. Our topic tonight is challenges in managing young patients with oral cavity cancer. My sincere apology that our email invites create some confusion regarding the topic. We won't be discussing recover and speech therapy. This area is immensely important, and there'll be a separate webinar dedicated to our dietitian colleague and speech pathologists. For those who register for this purpose, I welcome you to stay back. I also like to take this opportunity to thank our Genesiscare colleagues, especially Moira Townsend and Professor June Corey for the joint effort in sending out the invite. Next. Audience will be mute throughout the webinar. Questions are very welcome and important to facilitate discussion. You can type them in a box after clicking the Q&A circle as per the slide. Tonight, we have a spread of great speakers across 3 disciplines and 3 states. I'd like to thank our speaker for dedicating their valuable time to make this webinar possible. It seems that we are seeing an increasing number of young patients with oral cavity cancer. Navigating our way to maximize cancer outcome while minimizing side effects is our ultimate goal, but remain challenging. It's my pleasure to introduce Professor Jonathan Clark next. Professor Clark has extensive bio. He held directorship for Chris O'Brien Lifehouse and Royal Prince Alfred of Academic Surgery. Professor Clark has over 350 publications under his belt and has raised 32 million in research funding. Not sure how you do that. He plays a vital role in Cancer Institute New South Wales. He has been made a member of the Order of Australia and honorary member of ASO HNS. I will hand over this session to Professor Clark.
Thanks, Eric. It's a real privilege and an honour to be talking tonight and looking forward to presenting some of our findings. Next slide, thanks. So I was asked to talk a bit about the research that we've been doing at Lifehouse around oral cancer, but it's really important that that I recognise the contribution that comes from so many of our collaborators, which without their work, none of this research is possible. Next slide, thanks. One of the key things that I wanted to talk about is that we are seeing a rising incidence in oral cancer. And when we looked at this carefully, as you'd expect the incidence to be going down as smoking rates are reducing in Australia, it was really in the patients with tongue cancer that we were seeing this rising incidence in patients under the age of 45, and even more so in young females who've never smoked. Next slide. So we started a program of research focused on young patients, and we're able to put together one of the largest cohorts of patients where we could do whole genome sequencing on patients under the age of 50. And I need to acknowledge the work that Lavinia Zakunaselan, who's one of our pathologists and PhD candidates, and Dario Stribnik, who's our bioinformatician postdoc, has done in this area, which has been amazing work. So some of the first things that we've been able to show, sorry, next slide, is that there is underlying genetic differences between patients who are young and patients who are old with oral cancer. One of those differences is that we're seeing the young patients have a much higher rate of whole genome duplication. In this cohort, it was 75% of patients. And you can see in the circus plot on the left at the top, that green line is the duplicated chromosomes in those patients. And then we've got the fish on the right demonstrating polyploidy. Next slide. The other thing that we found was that the tumour mutation burden was different in these patients. So younger patients appear to have a lower tumour mutation burden. And of course, that has some concerns if we're trying to treat these patients with immunotherapy. Also, we saw that that was lower in the females compared to the males. And so if you took the young females and compared it to an older male, even in this relatively small number of patients, we were seeing statistical differences in the TMB. Next slide. One of the other things that we observed was that there was about 1/3 of these younger patients were demonstrating EGFR amplification. And we weren't seeing that at all in the older cohort. So we've taken some of those patients and cultured their tumours and been able to demonstrate that they are more susceptible to EGFR blockade. And I think this, presents an opportunity for us to go back and look at some of the drugs that have been used in the past, like cetuximab, and see whether they may have a specific role in this cohort. Next slide. It starts to get a little confusing when you look at the prognosis of these patients. And we're all really influenced by the anecdote of the young patient who's done incredibly badly despite our best efforts. When we objectively looked at this data, and we were able to put together a fairly large data set of a few thousand patients by combining data with Prince of Wales and Westmead, some groups in India, Toronto, and Singapore, we actually found that younger patients in general did better. So if you match them according to the number of adverse features, overall, they actually had a better prognosis. And then when you looked at them according to their gender, there was a bit of separation. So the young females did well, but the younger males didn't. And I think this is something that, despite having a pretty big cohort, when you get down to these small groups, I think we need more data to really nut this out and figure out if that's a true phenomena and exactly what's going on. Next slide. So if these younger patients are living longer, then we need to think about their functional outcomes in the long term. And some of the research that we've been doing in our jaw reconstruction cohort has shown that younger age is associated with worse functional outcomes in terms of their self-rated appearance, smile and speaking, greater distress associated with those sorts of functions, and not surprisingly high cancer worry. Next slide. So I guess this is, the question is, how are we going to make a difference here? How are we going to impact it? And of course, we need to do more research. That's a given. And we all know that oral cancer is not well funded. But do we know how badly it's underfunded? And there's been some recent studies that have come out that actually shown that oral health diseases have the greatest funding inequity compared to any type of disease, 10 times lower the average in terms of funding. And that's despite the disease burden that these patients have. Next slide. I think one of the things we need to start thinking about it as a group, as a society, is how we can monitor outcomes. And I think clinical quality registries are really important. It's really important that we're monitoring our data. And also, if we're going to start making an impact on patients' morbidity or their survival, we need to be able to measure their outcomes. And so we need to plan for this in advance. And I think if we were able to work together as a group to put together a clinical quality register for oral cancer, that'd be a really important step forward. Next slide. And so this is work that Rebecca Venturuti is doing with Ashley Sharman. And at the moment, we're in a phase where we're establishing what the quality indicators would be. And this is work that she's doing with a number of collaborators across Australia. And so thanks to anyone who's been contributing to this. And then the plan is for us to move on to a pilot quality registry for oral cancer. And I think oral cancer is a really good one for us to use because it often involves or routinely involves multidisciplinary treatment, and it is a really well-defined cohort. Next slide. So, there's a few ways we can tackle the morbidity that these patients have. So one way would be through, trying to minimise the unwarranted clinical variation, and that's where clinical quality registries come into play. But also, I think we should be thinking about how we can reduce the role of radical therapies. And as you know, I'm a surgeon, so I'm trying to do myself out of business here. Next slide. So this is a trial that we have underway, and I'm really privileged to work with an amazing team: Ruta Gupta, Jenny Lee, Helen Rizos, Jean Yang, Marina Pajic. And the way that this trial works is that we take patients who are at high risk of recurrence, and they undergo standard treatment, but we collect their tumours at the time. And then we do about 6 streams of assessment, which ranges from genomics, transcriptomics, immune profiling, cell cultures, explants, and then we do drug sensitivity testing on those, so that if the patient recurs, we can offer them a drug therapy that's tailored to their tumour response, rather than treating them with salvage surgery. And I think this is a really important concept, because salvage surgery is the most morbid operation that we do, and it really leaves patients severely disfigured and with severe functional impairments. And we all know that the chances of curing them in this situation is extremely low. And I think it's a good point, a good starting point for us to try and change our treatment paradigms. Next slide. So yes, we can try and change our radical therapies. Next slide. But also we should be looking at it from the other perspective, which is how, if they're going to undergo surgery, and we know there's always going to be a role for surgery, how can we restore their form and function better through better reconstructive techniques. Next slide. And also how we can rehabilitate these patients better. Next slide. So one of my areas of focus has been looking at how we can deliver better dental rehabilitation. We all know that dental services in Australia are underfunded. Sometimes you can put these patients through these incredibly long and morbid operations, and the entire cost of the surgery might be less than the dental prosthesis at the end of the operation. So we've been working on ways that we can expedite the delivery of dental rehabilitation and deliver it at lower cost to patients. Next slide. So the concept of jaw in a day is not a new one. There's been centres doing that around the world for some time, but we're trying to match that with our own 3D printing services so that we can provide low-cost dental prostheses to this patient. So next slide. When a patient has to undergo these kind of radical operations, they can walk out of the operating room with teeth, and that's going to potentially have a big advantage in terms of their functional outcomes. Next slide. But I think it's really important, if we're trying to deliver innovative care, that we are monitoring these outcomes, and that we're not just doing that as cowboys trying things. We're monitoring what our outcomes are and demonstrating whether they're actually delivering improvements to our patients. So we've been able to show already that virtual surgical planning improves quality of life in patients undergoing maxillectomy, and increases or decreases the time to dental rehabilitation. But I also want, when we're measuring these functional outcomes, that we can apply these in real time for our individual patients. And this is an example here of a patient named Nicola, and you can see that she's undergone, well, you can't see, she's undergone a jaw reconstruction, and most of her functional outcomes are really good, but you can see that her appearance has not improved over the 12 months after a surgery. So next slide. In her case, we went back and we looked at her original planning and her preoperative scans, and then we looked at her postoperative CT scans and soft tissue, and then we've overlaid those images, and we can see that the the overlay of the bone is pretty good, but there's a real deformity there in the right lower chin region in the soft tissue. Next slide. So in her case, we've done the obvious. We've gone back, we've debulked it, and you can see that that is then translated into better appearance functional outcomes. And this is just a nice anecdote to try and demonstrate that monitoring these things, it's not just research, it can really impact the lives of our patients. Next slide. The final thing I just want to mention is trismus. And as we've been doing more of these jaw reconstruction cases and things get more complex, trismus has been a big problem for us. Next slide. And trismus really impacts the quality of life of our patients. And I want to highlight the work that Emma Charters, our speech therapist, has been doing, speech pathologist, I should say. And we've developed a 3D printed jaw stretching device called RestoraBite. We all know that if you want to get a TheraBite, it costs you $600. This is, about 1/8 the cost of that. And when, again, not just trying to put this out there, I've got a whole program of research around that Emma's developing. And we've been able to develop some collaborations now with Peter Mack, with Jackie Frowen, and with the MaxFax team up in the Gold Coast, where we'll be running a randomized controlled study. We've already done a prospective study of 140 patients showing better outcomes, but there's a whole program of research around this. Next slide. So this is my final slide. And really, it's just a call to try and encourage collaboration. It's hard doing this research, and I think we'll all benefit the more that we're working together on these things. And I think the ANZ Society can have a big role in these areas, in trying to advocate for clinical quality registrars, potentially in coordinating multi-centre trials. If we wanted to test cetuximab in a group of EGFR amplified young patients, the drug companies aren't interested in this. There's no money in that drug anymore. So, it's going to be up to us to do it. And there's a role for the society in advocating around oral cancer research and dental rehabilitation and dental care. Thanks very much.
Thank you, Jonathan. What a fantastic talk. It's so great to see so much innovation and research and restorative work coming out in this space. We'll see whether we can unpack some of the area, particularly looking at the clinical quality registry towards the end of the sessions. Love to know more about it. Please use the Q&A chat function for your questions. Next, I'd like to invite our next speaker, Dr. Melanie Jackson. Melanie is a radiation oncology practicing at multiple sites in Perth. Next slide. She's a head of department at Genesiscare, Wembley. Mel is committed to the continued improvement of patient care through research and delivery of quality treatment. She's the chair of the Genesiscare National Head and Neck Cancer Reference Group. Mel, it's great to have you tonight. I'm looking forward to your talk. Next slide. Mel, can you unmute your speaker, please?
Oh, sorry. Thanks. Thanks, Eric. It's an honor. Sorry, it's a pleasure to speak before you all tonight, especially with these other two great speakers as well. I learned a lot from Professor Clark's talk and found that tumor mutation burden really interesting, and also be very interested to further discuss tumor registries. I'm going to be speaking about some of the challenges that I face as a radiation oncologist managing patients with oral cavity cancers. Next slide. So I had to think about it, and these were my top three. So one, in determining in the MDT who needs postoperative radiation therapy. Secondly, and one of our biggest clinical challenges is managing the side effects of radiation therapy. And thirdly, retreating a patient with oral cavity cancers. Next slide. So very briefly, in just one slide, there's often discussion about who would benefit from postoperative radiation therapy. So those who need radiation therapy and who recommend radiation therapy for are those with advanced primary diseases, T3 or T4 primaries, patients with positive or close margins, and also patients with perineural or lymphovascular space invasion. It's reasonable to omit radiation therapy if there's only one node, or if the primary is very small and there are no other adverse features, and if they've had a good neck dissection. Next slide. So onto the side effects of radiation therapy. Next slide. So there are significant acute side effects of radiation therapy, and they include mucositis, skin reaction, loss of taste, and dysphagia. Mucositis becomes evident about in the second or the third week of radiation therapy. And the incidence and the severity depends very much on the radiation volume, the dose fractionation schedule, and the use of concurrent chemotherapy. Next slide. Late complications of radiation therapy, that includes fibrosis, osteoradionecrosis, lymphedema, and trismus. Xerostomia, that starts during radiation therapy and usually persists after the treatment. The recovery of xerostomia in patients with oral cavity cancers, it's more limited than people with other head and neck primary sites, because there are higher doses of radiation to the submandibular glands, and there's also a larger volume of oral mucosa and minor salivary glands in the radiation treatment fields. Next slide. A lot about the management of the side effects of radiation therapy comes with prevention. So mucositis, it's managed symptomatically with scrupulous oral hygiene, including optimizing dentition prior to radiation therapy, dietary modifications, treatment of superinfections, and topical agents and analgesics as well. So as many of you know, pain is quite significant during and shortly after a course of radiation therapy. So long-acting opioids with breakthrough should be used as needed during the treatment period. Next slide. And as I said earlier, dental has a significant effect on the post-treatment quality of life for patients with head and neck, or all head and neck cancers. Many of the patients who have oral cavity cancers have poor pre-existing dentition and dental health. And there's an increased risk of complications from their cancer therapies, including osteoradionecrosis and infections. So any extractions and restorative work should be done prior to a course of radiation therapy. Next slide. So moving on to the topic of re-irradiation. Next slide, please. So this is a patient who was presented in our MDT recently. So this is, previous slide. So you can see from the previous, the surgical clips on the right side of their neck. He's had a previous oral cavity cancer, had it surgically resected, has had a course of radiation therapy a few years prior, and now presents with another oral cavity cancer. So more and more as a radiation oncologist, I'm being asked to see patients for re-irradiation. You know, once upon a time, you treat an area once and that's it. And you just say, look, I've treated it once, I can't treat it again. But especially in the new era of immunotherapy and people living longer with targeted therapy, and also in the setting of metastatic cancer, where once we would treat an area once, I'm being asked to treat lungs again and brains more than once. So it's really become quite a big topic for a radiation oncologist, and what we do is from one radiation oncologist to the next it can be very variable, and of course it's patient by patient and case by case. For patients with oral cavity cancer, about a third of patients with oral cavity cancers would develop a second cancer within 5 to 10 years of the original diagnosis. So why are second cancers so common? There's improvement in the cancer cure rates due to advancements in early diagnosis and treatment, extending life expectancy. Additionally, there's sometimes genetic dispositions, exposure to several dietary and environmental carcinogens, immunosuppression, radiation carcinogenesis, and even oncogenic virus infections, which tend to increase the incidence of double and multiple primary cancers in one person. Next slide. So there's no straightforward approach to head and neck reirradiation, and it is different from one radiation oncologist to the next, and again different from one patient to the next. So we all want to balance the risk and benefits of treatment to minimize morbidity and maximize quality of life and survivorship for patients. So the treatment options include 1, additional surgical resection, 2, reirradiation with plus or minus chemotherapy or immunotherapy, or 3, immunotherapy or chemotherapy alone. Or another option would be for patients to have neoadjuvant chemotherapy first, and for them to be restaged, and then to assess the biology of their new cancer. So overall, in our MDT, surgical resection is the cornerstone of therapy for patients with resectable recurrences, who haven't previously had big operations and can have an operation. Post-operative radiation therapy, there are retrospective studies which show that there's not a lot to be gained necessarily by having reirradiation. So really, we're just saving this for radiation therapy for the more high-risk patients. Next slide. So the indication for reirradiation are patients who've had salvage surgery but still have high-risk features after that. So if they've got positive margins or extranodal extension, or patients who are medically suitable for curative intent interventions, but they can't have a curative resection for some reason, or patients who are not candidates for curative intent interventions, but can benefit from some palliative radiotherapy. Next slide. So the tissues of the head and neck, such as the skin, the nerves, the blood vessel, spinal cord, they've all already received quite a significant amount of radiation therapy and doses with their first course of radiation therapy. So reirradiation exposes these tissues to further more radiation, and the risk of severe complication, it goes up exponentially. And that includes things like carotid artery stenosis or rupture, osteoradionecrosis, pharyngocutaneous fistulas, non-healing skin ulcers, spinal cord damage. And the risk of these are lower in the VMAT IMRT era, but I still counsel all my patients that with reirradiation, regardless of the cancer, or for all cancer sites, that there's potential significant risk, including the risk of death. Next slide. So generally speaking, radiation volumes for people who are having reirradiation are smaller than when someone who's having a radical or initial course of radiation therapy. So instead of treating, say, an entire neck or entire organ, it's usually just the gross tumor volume plus like a 1 or 2 centimeter margin, and even less if it's around critical structures such as the chiasm or another optic structure. So, this approach was actually validated in a retrospective review of 66 patients who had reirradiation. And they found that actually 96% of these patients had local regional recurrences following radiotherapy. And there was only 4% of people who recurred in regional sites that were not treated. Next slide. So for radiation to be effective, we need to give more than 50 gray really to get a substantial response rate and to delay any disease recurrences. And many investigators and cooperative groups would use about 60 gray as a target for reirradiation dose. So there's large analysis to demonstrate that patients treated to higher radiation doses have more improved outcomes and tumor control. there's no consensus on the total dose of any particular radiation dose fractionation scheme. But where possible, if somebody has Crohn's disease, it would be good if we can get them up to 70 gray. And for those who are treated after they've had a gross total resection, we're aiming for between 60 to 66 gray. Next slide. So other considerations with regards to reirradiation, second cancers fare better than someone who's got recurrent disease. Longer time intervals between treatments also affords for better prognosis. People who have laryngeal or nasopharyngeal cancers, those head and neck sites have more favorable prognosis than people with other head and neck sites. Recurrences in the neck, if somebody recurs there, they fare much poorer than someone who recurs in a primary head and neck site. And also, generally speaking, people who have higher doses of radiation fare better and yield better outcomes as well. Next slide. So that's mostly what I wanted to cover. Thank you all again for your attention, and I'll pass you back to Eric.
Thanks, Mel. A great talk. Thanks for stepping us through the challenges that radiation oncology face when treating the head and neck cancer, and give us a good insight in terms of retreatment. Yeah, I must admit that when dealing with retreatment, the first step is to manage myself first. My heart rate tends to go up, and I try to avoid at all costs. But obviously, if for patient where there is no surgical options, or in post-op setting where you want to increase improve the local control, you just have to bite the bullet and do it that way. Thank you. Yeah. Again, I just remind the audience to send questions through the Q&A chat function. Our third speaker is Dr. Marcin Dzienis, my dear colleague, whom we stand shoulder to shoulder in troubleshooting our head and neck patients daily here in Gold Coast. Next, Marcin is a Director of Medical Oncology Service at Gold Coast University Hospital. He completed his undergrad training in Poland before migrating to Queensland, where he completed his medical oncology training. He undertook a combined head and neck and skin cancer fellowship in Brisbane. He provides patient care with international clinical trial involvement and links to Griffith University. Over to you, Marcin. Thank you.
Thank you, Eric. Looks like we're on time, so I'll try to stick to my time allocation. Next slide, please. So as a medical oncologist, my main involvement with oral cavity tumor patients is to decide whether or not to add cisplatin to their post-operative radiotherapy. But there are occasional situations where decisions may be a bit more complex. Certainly with more advanced tumors and younger patients who can take more intensive treatment, use of induction chemotherapy may sometimes be raised. And also questions from the patients who may not fit the typical patient population and may ask questions as to why they developed that type of a cancer. And next slide, please. So on to induction chemotherapy. I think that the next few slides can be summarized by this, underlining here, great start, average finish. Next slide, please. So TPF is the typical induction chemotherapy regimen. That's the docetaxel, cisplatin, and 5-fluorouracil. There's a bit of a variation in dosing as seen here, and are both investigated in phase 3 studies. It is by far the most effective systemic treatment option in head and neck cancer. Responses are seen in almost 3/4 of the patients who are treatment naive, importantly. Those responses may not be replicated in patients who have had a pre-treated disease. However, for the treatment naive patients, somewhere between 9 to 17% can have a complete response to this treatment. However, it is associated with substantial toxicity, including toxic deaths. The rate varies from almost close to 0 to up to 5%, so 1 in 20 patients. So patient selection is critical for this treatment. Next slide, please. Even before TPF was around, and considering morbidity of treatments delivered to oral cavity, there was some interest in using the older induction chemotherapy, so just combination of cisplatin and 5-fluorouracil. Here showing a trial of almost 200 patients, randomizing them equally to the 2 arms. And the authors did show that there was some modification of morbidity of the local treatments, as you can see. Mandible resection down to 31% from 52%, and lower use of post-operative radiotherapy, indicating fewer high-risk features in the resection specimen. However, as you can see on the graphs, the survival of those patients wasn't altered in one little bit. And although a longer follow-up showed that there was some decrease in long-term toxicity, mostly stemming from a lower use of radiotherapy, this does not take into account the acute toxicity from the induction chemotherapy. And so the role of this treatment remained uncertain. And next slide, please. And so once TPF became the more effective and preferred treatment option, another look at what it could achieve for patients with oral cavity tumors was undertaken. Here, a slightly larger trial with just over 250 patients, again, equally randomized to 2 arms. TPF with lower doses, only 2 cycles used. First of all, the authors showed that the timing of surgery and radiotherapy was not affected by the induction chemotherapy. And they have shown quite an impressive, 80% response rate, with even more notable 13.4% complete response rate in the surgical specimen, so no evidence of tumor. And also the rate of distant metastasis was lower in the induction treated patients. However, due to low numbers, that difference was not statistically significant. However, once again, you can see in the graphs on your right that the relapse-free and overall survival was not altered. And although the authors undertook some exploratory analysis trying to show that perhaps those with more advanced disease did derive some survival benefit, that's obviously just hypothesis generating, and the study wasn't powered to answer that question. And again, with just modification of some early treatment outcomes, but no impact on long-term outcome, the questions need to be raised about the role of induction chemotherapy. And again, here you've got 1.4% toxic death earlier on treatment from induction chemotherapy. And the next slide, please. I had a look at our patient cohort. This is not by any means matching what was done in the previous trials, which were in the 2 trials that I showed, because obviously those were patients with resectable disease, whereas in our unit, patients who are resectable or even borderline resectable will preferentially undergo surgical resection, which is the most effective treatment option for those patients, with usually with radiotherapy or chemoradiotherapy following. So the use of induction chemotherapy in our unit would be limited to particularly advanced tumors that are clearly not resectable, and perhaps even feasibility of radiotherapy may be questioned. There weren't that many patients here that we treated in this manner. 7, as you can see, 3 males, 4 females. The median age was 57, which is a bit younger, but that obviously speaks to the patient selection. They need to be fit. Although, as you can see, one patient was 74, and surprisingly, she actually did her outcome was the best, and she managed 2 cycles of induction chemotherapy and full chemoradiotherapy very well. So it's probably speaking more to the biological age. Overall, we are on average delivered 2 cycles of TPF with a bit of a range there. There were no toxic deaths, but 2 patients actually progressed while on treatment, which is proportionally higher than you would expect. But at least one of those patients with heavily pretreated, it was to allow re-irradiation. So that's probably where you would expect lower efficacy of your treatments. So ultimately, only 5 underwent chemoradiotherapy, with only 2 of those actually having the desired or prescribed doses of chemotherapy delivered. And for the other 3, the chemotherapy had to be truncated. That may be partly because of the use of TPF, but I would argue that it may be for those patient population, it's the fact that it's large radiotherapy field delivered in oral cavity. It would always make chemotherapy delivery a bit more difficult. Despite this, intensive treatment, 3 of those patients still had residual disease. And although 2 had complete response, 1 unfortunately had new lung metastasis noted on her post-treatment scan. Only 1% of those patients was deemed suitable for rescue surgery, but even in that case, there were multiple positive margins. So 4 patients, so apart from that 1 who had truly complete response, went on to nivolumab. And at the end of the day, with all those treatments along the way, we've managed to render 3 patients clear of disease, with 1 patient stable disease on nivolumab for 2 years before dying, and 1 patient progressing rapidly despite all those treatments and dying unfortunately early on. So those three patients with complete response are still alive. However, 1 of them, and that's the oldest patient, relapsed locally after 2 years of remission, and she's decided against rescue surgery at this stage and will consider some palliative treatment options. So ultimately, probably not the prettiest picture, but very, very advanced tumors. And again, would they do equally or similarly well or unwell if we skipped induction chemotherapy? Remains somewhat unanswered. And if I could have the next slide, please. So the role of induction is still very unclear. There's some impressive upfront efficacy, but there's no meaningful long-term impact. And the substantial upfront toxicity really makes it quite questionable. There may be a rare patient that benefit from this approach, but it's still hard to be certain who those patients are. We mostly make the judgment based on a patient's fitness and ability to tolerate this treatment rather than ability to predict who may benefit from this burdensome therapy. And if I could have the next slide, please. So now onto the etiology and beyond the typical risk factors. Next slide, please. So as you all know, most prevalent risk factors are smoking and alcohol, and there may be a role for second-hand smoking, particularly amongst those who were exposed early on in life or over a prolonged period of time. Interestingly, amongst passive smokers, women seem to be a bit more prevalent than men. However, that would not be explaining the younger women phenomenon, since even with passive smoking, you need a reasonable amount of exposure, so it's older women. If I could have the next slide, please. So HPV has been implicated in the etiology of some oral cavity tumors, probably fewer than 5. However, a large retrospective review from the USA identified almost 10% of women with oral cavity tumors that appear to be driven by HPV. Importantly, P16 testing for those tumors is not reliable. In one of the reviews that's listed here, although 6% of those tumors were P16 positive, only a third of those truly harbored HPV as the causative agent. And if I could have the next slide, please. There's some renewed interest in herpes simplex virus as a possible cause. There's been some investigation around this going back to the 1990s. Where some serological studies noted that patients with oral cavity tumors had higher antibody titers to HSV, and also different subclasses of immunoglobulin elevated, indicating altered immune response to that virus in patients with oral cavity tumors. However, the presence or the role of this virus seemed to be still linked to smoking, and was thought to be more likely a cofactor in carcinogenesis rather than the sole cause for developing those cancers. And certainly animal studies, seem to indicate that that was the case, that it was rather a cofactor than a reason by itself. There's a very rare evidence of HSV1 in the tumors. There's no integration as seen with HPV. And so there's this working hypothesis of hit and run, where the HSV triggers or starts the cell on the path to developing into a cancerous cell, but it's lost along the way. There's no proof to that hypothesis, but there is definitely some renewed interest in looking into HSV as a potential trigger. due to the increased incidence of oral cavity tumors amongst particularly the young female non-smokers, as we heard earlier on. And the next slide, please. Now, immunosuppression is a known risk factor for patients with cutaneous SCC, not so much for mucosal SCC. However, there's a small group of patients who are immunosuppressed who seem to have an increased risk of oral cavity tumors. That's the bone marrow transplant recipients, particularly those who had graft versus host disease, and especially if it was directed at the mucosa. The time between the transplant and the cancer can be a decade or so, but with quite a wide range of timing. And the overall prevalence in one study was put it at almost 6%, so triple that of general population. And the next slide, please. And obviously, particularly with young patients, looking at the potential genetic factors would be a place to look. However, there's no germline mutations that are strongly associated with oral cavity tumors or in any head and neck mucosal SCC. There's some polygenetic susceptibility, but more increasing a patient's risk from known carcinogens rather than driving the cancer by itself. Fanconi anemia is a rare autosomal recessive condition that stemming from the homozygous loss of double-stranded DNA repair deficiency. It results in bone marrow failure and multiple malignancies, predominantly hematological, but there's a slightly increased risk of oral cavity tumors amongst those patients as well. And the next slide. Finally, there's a link between using alcohol-containing mouthwashes and the development of cancer. The link is weak, but it's seen for both oral cavity and oropharyngeal tumors, and a bit more meaningful for those who use alcohol-containing mouthwashes for a prolonged period of time, over 35 years or multiple times through the day. There's been 6 different epidemiological studies looking into this. And a systematic review of those studies found mixed results, meaning 3 showing the link and 3 not supporting the link. However, when you look at the numbers, those studies that showed that there is a link included twice as many patients than those without showing that association. And perhaps for a very slight or minor increase in risk, you do need higher numbers to show that. And just next slide, please. However, before you give up on your mouth hygiene altogether, just be mindful that it may still remain important and protective against developing of oral cavity cancer. The bar is not high. If you lost fewer than 5 teeth, you're good. If you pay a visit to your dentist at least once a year, you're also better off than those that don't. And even brushing your teeth once a day seems to be a protective factor against oral cavity tumors, as is lack of gum disease. So don't give up on those mouthwashes and other ways to look after your oral cavity. And the next slide, please. And that's this from me. Thank you.
Thank you, Marcin. Perfect timing. Yeah. With the remaining 10 minutes or so, we'll skip through the case discussion. We'll have some opportunity to ask a few questions. Perhaps I first ask this question addressed to Jonathan regarding the clinical quality registry. Can you step us through what is needed and how does it help to reduce clinical sort of variations? And how can we participate?
Yep. So the process that Rebecca's working on at the moment is to do a modified Delphi study, and so that's to work out what are the variables, the clinical quality indicators that we should be collecting based on the existing evidence. And there are a lot of indicators out there. So that's a really important step because, we're starting with several hundred potential quality indicators, but we've got to be realistic about what's going to be collectible. And we need to be able to get that down to a manageable number that's supported by evidence. So, you know, examples of things that probably would be included would be time to radiotherapy after surgery, for example. You know, there's existing data out there. And these sort of metrics are good because they are the sort of thing that potentially can be automated. And I think the reality here is that for this kind of process to be successful, we need to automate the collection of data as much as possible. It's most unlikely that if we're relying on individuals in institutions to provide that data, one, it's not going to be reliable, and two, it's not going to happen. So we need to be able to find indicators that in general can be automated in that data collection. And then, you know, there's going to be an issue here around people willing to sign up. And it's inevitable that everyone's going to feel, you know, concern about what's going to be done with the data. You know, I think that's a big issue, but this kind of data is so important. And it really is the low-hanging fruit, I think. And I think if we're in an institution, and if I'm in an institution where my clinical outcomes are not at the level they should be, I want to know about it. And I want to then use that data to petition for additional funding to rectify the problem. So I think it becomes quite a powerful tool to try and achieve standards across Australia or across the state, you know, whatever we can achieve. And it's a powerful tool to be able to petition government and administrators in institutions for additional resources and funding. And I think, you know, we would all benefit from that.
Thank you. Yeah. Say if another site from another state like to imitate, is it something quite transferable?
Yeah. So look
from scratch, you know.
Yes. Sorry, I didn't answer that part of the question. So, you know, it is in its early stages at the moment, you know, and this is going to be a work that happens over the next 5 years. It's not something that's going to get rolled out in the next 12 months because we want to make sure that the data, the quality indicators are appropriate and they are usable, and that we can put systems in place, you know, using things like machine learning and AI that would allow us to be able to collect this data automatically. And so I think we are at that sort of point now as we're seeing healthcare start to become more online and transferable, that there are these opportunities for us to be able to collect that data across institutions, across states, and across national boundaries. But we do need to be all on board with the concept. And I think that's really one of the keys, is that as we put this together, it's not just work done by one institution, it's work that's done as a group, as a society, that we all serve in.
Thank you. Yeah, we'll watch the space and watch the publications and outcome from your center closely. Another questions from the audience to Mel. What is the role of proton therapy for oral cavity cancer? I guess you can break it down to in a setting of recurrent perhaps, or even, you know.
Yeah, so generally speaking, the use of proton therapy is to minimize radiation dose to a critical structure. So we're talking things like optic structures or the spinal cord, an organ that can't receive a high dose of radiation compared to what dose is required for curative intent treatment. So things like chordomas or head and neck cancers next to the eye, where you really want to be sparing patients' eyes, for example. But for people with oral cavity cancers, in the first instance, you know, they're needing their entire neck treated, or they're needing their entire oral cavity treated. So the role of protons in that situation is probably a little bit less. If someone only truly needs a small area treated, then it probably would be good to use proton, because they'll minimize any long-term side effects, minimize any need for feeding tubes. So there would be the odd patient where it would be useful over you say using VMAT. And like you said, for patients with who are having retreatment, if there's a big problem keeping the spinal cord dose down, or if it's near the base of skull, in those situations, proton therapy would be quite useful. And I just also wanted to just say that we do. I'm very lucky to sit on we have a head and neck cancer reference group in Genesiscare, and we come together from many different states, and we do have it's taken a little bit of time to get here, but we have identified what quality information we want to collect, and we have started the process of actually inputting into our Horizon, which is where we input all patients' information and data and so forth. So things that we want to know before they start treatment, and then we've also now got an interface where we're trying to collect the outcomes. So what's happening to them at the 3 months, 12 months, and onward mark. And there's been a recent audit just to compare the information that's been input into the system to what's in the clinical notes and what's in the radiology and so forth, and it's been quite good. So clinicians have been quite good at inputting the information quite correctly. So that's something we're working on too, and I think will pay off very well as well for patients.
Yeah, it's something I neglected to mention. Having groups like Genesis, which go across different state boundaries, is a great opportunity, and that's the sort of thing that we would love to collaborate with, because it provides that opportunity to collect data Australia-wide. So I think that's fantastic.
That's fantastic. Yeah, really looking forward to the how-to. Certainly, there's a lot of work in the background, and in order to sort of start that from a center which has no record of that, is going to be a lot of effort. So hopefully we can hear more about that in our ASM at some stage. Yeah. On that note, I think next slide, please. I'd like to conclude the session tonight by making a few announcements. First, I'd like to invite all of you to continue to contribute scientifically and socially to our annual ASM. This year will be held in Hunter Valley from the 10th to 12th of August. Detail is available in our website. Next, I also would like to invite you to join force with us supporting the society by becoming a member for a nominal fees. It's a small society, and the more people involved in it, I believe it's going to make a huge difference in the long term. So please consider that. Next, donation to our research foundation, enabling ongoing research for our head and neck patients. Welcome. Donation is tax deductible. Next, please visit our ANZ Head and Neck Cancer Society website for ongoing information and update. Next, our next webinar is in May this year, just 3 months away. So detail will be available soon. Once again, please join me in thanking our speaker today, Professor Jonathan Clark, Dr. Melanie Jackson, and Dr. Marcin Dzienis for their time and effort, and what a fantastic update for challenges that we face in managing oral cavity cancer in young patients. Thank you, take care, and good night.